Good afternoon. Uh, my topic is the disturbing symptom after very good cataract surgery. What are the reason and how to deal with it? Even with technical perfect outcome after cataract surgery, still patients are unhappy. And there are multiple visual complaints as we know all faces day to day. We six patient is six, but he is unhappy. We are happy, but he is unhappy. In majority of cases, the proper conversation with patient can fix the source of unhappiness. We can realize what is his problem, what are his expectations. Sometimes they might be having an unrealistic expectation, which we have to overcome. Common disturbing symptoms are regarding refractive outcomes. Sometimes they are unhappy with your 0.25 correction, dysphotopsia, which is one of the more common cause, and dry eye. And sometimes rarely the patient come with the drooping of the lid. Now, come to the refractive surprise. When to anticipate refractive surprise? Extremely myopic, hyperopic eyes, very large, very small eyes, post-RK, PRK, LASIK, post-PK patient, especially post-RK patients. There sometimes you get a very unpredictable result even after calculating all type of the power from all of the recent formula, because that are not, and we in Indore, because we have the majority of RK patients, we are facing more of them. Most common cause limitation of precision and accuracy of biometry, especially in high myopic and high hypermetropic eye. Inherent uncertainty of IOL power calculation formula due to unpredictable final effective lens power. Imprecision determination of corneal power due to previous keratorefractive surgery. Variables such as capsular bag diameter for which no precise and practical measurement technique exists. Tear film abnormality, SPK, sometimes PCO, cystoid macular edema, capsular changes, capsular constriction can lead to forward displacement of IOL and can lead to the myopic shift. So sometimes you get a refractive surprise. What we can do? We can correct with the glasses, contact lens, corneal refractive surgery, lens exchange, piggyback. There are the multiple options. Then we have to overcome this. Want to do with refractive surprise? Stay calm, be patient, advocate. Don't let the situation become adversarial. Preoperative oil counseling can help prepare patient for surprises, especially multifocal. When we say the multifocal, you will not get glasses for distant needing, and if your counselor has pushed him forward more, we will be in trouble. So always under promise, and always I say to my patient that these are the possibility, but you will get some number for distance and some number for near. And if he didn't get, then he is more happy. So this type of symptoms you can see: glare, halos, and starburst. Many times patient complain that light chamakti hai, ye hota hai. What are the positive? Bright artifact of light, halos and arc causes higher refractive index of the lens, square edge lens, decentered IOL. Negative is a temporal. Many times patient come, there is it's moon-like shadow on the temporal side. These are the negative dysphotopsia. Small pupil, large gap between iris and intraocular lens. There are multiple other causes of dysphotopsia: tilted intraocular lens. Sometimes one haptic is in the bag and one haptic in the sulcus. Misaligned toric IOL, posterior capsular opacification, square edge lens can give the glare, surgery-induced astigmatism, and the post-operative dry eye. So needs preoperative workup, treat ocular surface disorder first. Then we go to the aberration. What are the optical aberration? Lower order, higher order. Spherical aberration occur when the light rays are over refracted at the periphery of the lens. In normal population, mean corneal spherical aberration is plus 0.272 plus minus 0.10 micron. Corneal spherical, so you have to select the lens, corneal spherical aberration plus value, negative defocus posterior, best vision, corneal spherical negative, positive defocus. So this help in the choosing the intraocular lens, whether we have to use with a spherical zero spherical aberration or the minus spherical aberration or so these are the lenses which are having the Alcon IQ has a positive spherical aberration. Otherwise, AMO, Bosch and Lomb, they are the minus spherical aberration. Technis and Bosch and Lomb is the 0, which we can measure with the pentacam, eye trace, and different equipment available for the measurement. Assess the angle kappa, especially for the intraocular multifocal lens. What we use once you get in a spherical aberration or this glare and halo, a repeated assurance to the patient, a counseling, gradually the brain get adopted and it takes 2 to 3 months to get adopted to this spherical aberration or dysphotopsia. Then another option, give the spectacle which is slightly thicker frame, so it obstruct the peripheral rays coming to the area and then symptom gets reduced. Correct dry eye, and if the refractive error is much more, correct that also. During surgery, well center in the back, you should keep in mind, ask the patient to stick to see in the light center of the lines, and then your lens should be the center there. So this is one of the important point, especially for EDOF and multifocal lenses. Brimodine and pilocarpine drops in positive dysphosphopsia, in some cases it helps. In the second eye, then you consult and switch to the round edge or silicone lens edge or plate haptic lenses which have the periphery lens material also. If it still persists, you can exchange that after 3 to 6 months. Don't mistake dysphotopsia with the PCO. Evaluate posterior capsule first thoroughly before yaw capsulotomy. This is one of the interesting case. Monofocal lens, patient was not comforted. I will show the eye trace also. All is well, but still I rotated this. It is a monofocal intraocular lens. AMO lens, and after, sorry, I will show you the rotation. Just we have rotated this because there was the capsular fibrosis. We have rotated this lens and prevented the fibrosis. And now you see that upper eye trace is the preoperative. Patient was definitely 6'6", Technis lens, but you can see in the eye trace that there is an halos and glares are there. You can see this. This is the images. These are the aberrations. And after rotation that you can see patient was happy, and now you see that it is all because that monofocal lens got slightly tilted because of the capsular fibrosis. These are giving the aberration. So his problem was benign. He was with the 6'6" vision, but his problem was benign, and if you assess that what is the cause of the error, you can correct it. Treat the ocular surgeon, so time is short, I will go short. So treatment, assure the most topical lubricating for the dry eye, punctum blood, dry eye tearing. Now the lid ptosis. Ptosis, sometimes that patient come with the, because of the overstretching of the superior rectus, topical anesthesia, risk of ptosis is decreased. Still occur in significant percentage of patient. Eyelid speculum, stretching, retrobulbar block, sometimes this can lead to the lid drooping is often short-lived. It can correct in the 6 months. Aprocolindin achieve up to 2 millimeter of lift. And if it is persists, you have to go for surgical take. So in short, take home message, dry eye problem before surgery, protect endothelium, conquer Jernicke's lower order first, good evaluation and intraoperative management of astigmatism, correct aspheric IOL selection, and correct selection of multifocal IOL can lead to a good outcome, and you can console your patient very well and can be patient can be happy. We cannot give 100% result, but then we can increase the percentage of our success. Thank you.
Thank you very much, Dr. Choudhary. And I would like to add one more thing. Those who are doing under peribulbar anesthesia, sometimes, the ecchymosis, the black spot, blue spots, the patients are more concerned about it rather than the vision. So again, the counseling and that is more important. We don't want to add any other treatment, but that is very important. Thank you very much for